Health Minister Zweli Mkhize is delivering his brief on the NHI. We cross there in Parliament now.
Productivity of their members, they've actually started talking about increasing the working age to beyond 72. So the issue, therefore, is sometimes we get frightened about looking at the extent to which we have actually disadvantaged our people. And we think that when we say we're saving money, we actually are on the right track when we're not talking about saving lives. And our issue is about saving lives. And so that is the approach we're taking in the issue of national health insurance. And in the process, if there is an issue of social solidarity, it means there are enough resources to look after those who need it most, because those who are well don't need it immediately, those who are younger don't need it immediately. As long as we embark on the programs to help with health information, social mobilization, and prevention of diseases and early treatment of complication screening and so on, and rehabilitation, all of these issues come into effect in that way. So then we then, however, asked the Treasury to look into the matter. They have suggested, in our memo that went to Cabinet, the Treasury has estimated that to run the structure would be looking at immediately about 57 million, and then slowly growing up 145 million the following year, and up to 287 in the MTEF. So that money is already within the system, so we're not talking new money there. Secondly, the Treasury has commissioned a simplified intervention-based costing tool for NHI, which provides a simple estimates cost for a set of 15 or so interventions. These include the examples of removing user fees, extending chronic medicine distribution in a program which we call it CCMTD, extending antiretroviral rollout, and increasing antenatal visits, rolling out capitation model for general practitioners, cataract surgery, establishing NHI fund, etc. The full set of these interventions, they estimate that in the longer term would be around additional 30 billion rands per annum. Now, so the Department of Health will adopt the tool to find a set of priority interventions, and then these interventions will be scaled up progressively, and then as we between now and 2020 we will not need new money. It will all be funded with reprioritization, as I spoke about it earlier. The Human Resource Capitation Grant to appoint staff to ensure implementation of NHI is already in the budget, and it's about 330 million on 18 and 19, and then goes to 600 million in 2019-2020, and will go up to 20 billion by 2021 in the outer years. So effectively, all of these calculations have been done by Treasury and have been factored in the budget that we are presenting today, and also in the outer years. The other issue was around the introduction of district management offices. District management offices, and particularly I think there was a question around the role of what they call CUPs, and the role of provincial departments and health districts managers and so on. So in effect, what will be happening here is that the NHI is actually going to be run as an entity of government. And that entity of government is an entity that will be focusing on the purchasing of the health services and providing for a particular district area and therefore a lot of its responsibilities are going to be devolved to districts, where we will be looking at district health offices, which will be the geographic area within which, when we look at services, we're going to be looking at. So when we talk about these contracting units for PHC, those will actually be working within that area as a way of bringing the authority closer to the area where the services are going to be purchased and rendered. And that is the approach. Now, obviously the powers and the roles and the functions of the Department of Health will be changing, and it will be distributed between the two responsibilities. On the one side, the purchase and purchase of health services and distribution and management thereof. On the other side will be the policy side and other areas of standards and health standards and compliance issues. So those will be run in that way. We're taking this from already models that are operating worldwide. So over the years, as we move on, we're going to be refining the legislative framework to be able to adapt to the situation as they're going to be needed at that point. So there will obviously be adjustment on the roles, responsibilities, powers. Where we are now is not where we were in 1994. In 1994, the roles and powers were based on a very different framework, and soon thereafter we embarked on a process which separated the provinces and national department into various regimes of power and roles and responsibilities and functions. And as you improve your system, you keep looking at that, and then things begin to change at that level. So we will be updating those as we move on with the situation. An issue which I can't recall whether it arose here or arose somewhere else in the House, but our reports right now are that there's been an improvement in the situation in oncology in KwaZulu-Natal. For example, the province has actually got 3 oncologists employed full-time. There's also an agreement with the WITS consortium, which will be providing oncologists, 3 oncologists every day. There are also 5 new machines that have been purchased, 3 at Nkosi Albert Lutuli and 2 machines in Addington. And the waiting period has also been reduced between 3 weeks to 10 weeks, down from 10 months, which is what has been raised before. So there's been intervention on this matter, and we're dealing with it. And in the past 3 weeks, we also had to get to work with them on the issues of drugs that they had concerns about. And this, again, is the whole department is monitoring the availability of the drugs that will be needed in oncology services. I think from the questions that had been brought to my attention, we have more or less dealt with those, and I hope you will share with the colleagues who might have arrived after I had answered the question they'd asked, because there's one more, which is what I was trying to check on. The issue of the implications of private medical practitioners and those using private medical care. It's not clear what the question is, but just to say, where we start is not where we'll end. Now, if you take most of the countries on NHI, the general practitioners are all working for the state on the basis of what we call capitation fee. So they take responsibility over a geographic area and the population size, and then the payment is based on the calculations made on the population that they've got to serve and the services, the basket of services that they've got to deliver. That helps to structure the different disciplines that they need to focus on in providing the care that will improve wellness and also early interventions so that they reduce the issues of morbidity. And in the process, what that does, it actually encourages people to stay healthy and not really to have an incentive of over-servicing and over-investigating, over admissions, extended unnecessary admissions, and all of that. So that is how that system works. In the process, in our situation, we're going through the discussions so that we will be contracting some of the general practitioners or family practitioners, and in that process, there will obviously be an agreed approach in terms of the payments, but the principle is that of capitation. The package is what we're refining in the meantime. The private sector, they already agreed to work with us in that particular area, as it were. Now, because we have not gone to a point where there is a complete a rollout of national health insurance, it will be clear that those on the private health private medical scheme will still be continuing, and therefore, as at the moment, it's a matter of the system is going to be slowly rolled out to involve those general practitioners, as it were. At the moment, it doesn't really affect anyone, but the issue is that we will want to start enrolling those general practitioners or family practitioners to actually assist to reduce the load of patient care on the health services. I hope that it does cover your questions, and certainly of the questions that I have, I've actually covered them all. Thank you very much.
Thank you, Minister. Colleagues, can I limit to 3 questions? The Minister has to mark. We are not conference area. Only 3 questions, please, colleagues. Mark, will you look in? Okay. Yes, Mark, and Romberg. Okay, this 4 questions.
Mark, the journalist. Mark.
Yes, abusing my position, I should say that I'm a journalist.
Now.
He's the
okay. Oh, okay. Oh, okay.
Minister, I won't repeat what I just said. It's just a question. In September of this year, September or October, we will receive the final report of the health market inquiry that was commissioned by the Competition Commission looking into the private healthcare market. We've already put out a preliminary report with quite substantive recommendations. I wonder whether you've had a chance to look at those recommendations, but also just how you see the recommendations of the health market inquiry fitting with your objectives when it comes to the implementation of national health insurance and the national health insurance bill.
Thank you, Mark. Next. Yes, please. Can you introduce yourself as you talk, please?
Good day, Minister. Paul Vecchiota from Bloomberg. 2 short questions. One is, will the first step be the incorporation of the government medical aid schemes such as GEMS, PolMed, the Parliamentary Office Bearers Medical Aid Scheme, so be the first step to incorporate those into the NHI? And will the benefits of those schemes be restricted to only accessing state hospitals, or will they be able to continue to access private hospitals as they can at the moment? And then, I'll leave that question for time.
That time being.
Thank you, Emmanuel Bell for Pretoria FM. My question as follows. It was I who put the last question that you dealt with regarding private practitioners and those who choose to use private medical schemes. The question that I was trying to put was that in your final analysis, in your end goal with the NHI, will a system such as private medical practice and private medical funds continue to exist in South Africa as coexistence with the NHI, or will the NHI incorporate all of those?
Thanks. Yes, please.
Hi, I'm Claudie from Business Day. I just wanted to find out, can you just explain to us the most significant difference that you guys have made to the revised bill now, from what it was when it was rejected by Cabinet, and what is the main difference in terms of what the bill looks like now? And just in terms of when is your, like in terms of timelines, when do you foresee that the NHI will be implemented in its full totality? Thank you.
Thanks, Minister. We are not going to take any more questions.
Okay. Just deal with the two. Yeah, difference on the NHI bill and the earlier one on the market.
Should I start first?
Yeah, you start.
Please.
Thank you very much. Thanks for the questions. I think firstly on the question relating to the health market inquiry and how we see this relating to the NHI, I think that the health market inquiry has a number of recommendations that reform the private health system financing, particularly the way medical schemes operate and are financed, but even beyond that, the way suppliers operate. So I think we need to take that on board and understand how best we can legislate some of this. I think some of it will relate to how the medical schemes amendment bill is currently structured, and we'll have to revise that. And I think in addition to that, we'll then have to look at the other recommendations and see how best they can fit into the proposals from the health market inquiry. So we're waiting for the final report to see what that looks like so that we can see how we proceed on that. On the question relating to the medical schemes amendment bill, sorry, on the NHI bill, sorry, your question was what the most significant difference is. So there have been a number of comments related to a variety of areas. So to say this is the most significant amendment, I'm not sure if I can classify anything like that, but I can tell you the areas where we had to make amendments. So the public, for example, wanted to understand how the NHI would operate in terms of medical schemes and how cover for medical schemes would happen relative to the NHI environment. So we clarified that. There was also questions relating, for example, to how the NHI would procure goods like medicines and equipment, etc. And the office of the Chief Procurement Office was then instituted within the bill. So those are the two clauses that are relating to that. On the governance side of things, there were a number of questions about how the board will be appointed, how the CEO will be appointed, and we've tried to make some amendments to take account of the public comments relating to that. There are obviously other areas that we instituted changes, but I'm not sure if I can call them significant. But the public will have an opportunity to see that.
Perhaps just on the market inquiry, you probably are aware that there are a number of recommendations that apply to different institutions and public entities, like for instance recommendations that apply to the Council for Medical Schemes, recommendations that apply to the Office of Health Standard Compliance. So there are different recommendations. So what we try to do is to capture some of them that are relevant when we're doing the work on quality. When the commission, the Lancet Commission, the National Lancet Commission, they started looking into some of the recommendations from the market inquiry that are relevant, that have a component of quality that could be taken into account. There are others that relate to licensing, for instance, and this work has already begun on how licensing will unfold in future, particularly the licensing of private hospitals and so on. The guidelines that have been developed underway, as you recall, there were these hearings that were held with different provinces, and specifically because provinces have different requirements for licensing. And as a result, we looked at how we could standardize that and make sure that all of them work from a standardized framework of licensing a private provider. So there are different recommendations, and we've tried to package them relative to that, so that by the time the report is formally released, at least certain things can start receiving attention.
Thanks, DG and Amnon.
Yeah, there were some comments from Dr. Ritlap and from Professor Gray.
Professor Ritlap from the HPCSA. The only comment we have is that there's a lot of work that we are looking at as a statutory council
on,
particularly on organizing the private practices better. Private practices are not registered. There are no standards. We don't know where they are. So we'll be coming with a legislative framework to ensure that that work gets done. And we hope by doing that we will be assisting the implementation of NHI and provision of better services where the resources that sit in the private sector can be utilized to the benefit of all citizens. We have 70% of our specialists sit in private practice, and a significant number of our general practitioners are in independent practices. So we will be doing that. We will also be looking at the ethical review of certain ethical rules to ensure that they are compliant with modern practice and they are compliant with the aim of ensuring that there's access to care and there's cooperation and we improve the regulations on team-based care. So that's what we'll be doing from our side to contribute.
Thanks, Dr.
So I'm Glenda Gray from the South African Medical Research Council, and as someone who was involved in operational research or the rollout of antiretrovirals and implementation science, I see very much the NHI as a process where you begin your rollout and you course correct and you evaluate all the time, and that what's important is to course correct all the time. And the demonstration projects that have occurred, one must learn from what went wrong and course correct to make things better. And as we roll out NHI, there will be changes, as we saw with ARV rollout. In the beginning, a lot of the ARV rollout happened with PEPFAR-funded NGOs. The next step was to put them into the health department. The next step was to move from doctor-initiated and doctor-led programs to nurse-led programs. So this is all in the process of correcting a process. So one cannot expect to be perfect and roll out the perfect program. But what is important all the time is to learn from our mistakes and our successes and implement that works and be pragmatic as we roll out the processes and learn as we go along. It is revolutionary and visionary for a low middle income country such as South Africa to take on a program that seeks to attain universal health coverage and national health insurance. And I think we should be excited by the ability for us to be involved in this program and embrace and work to make it a success for all of us in South Africa.
Okay, can we give you a direct question? We have not taken a decision to close down James of Parliament. So, there's no such a decision. Now, the question, let's answer it in the context of the last question. And the question was, do we foresee in the future the coexistence of medical aids and NHI? Now, the issue is that we expect that the NHI should cover all South Africans and offer all the services to South Africans. Then there will be a number of areas where there may be services that the NHI might not be offering or might be offering them in a particular way, and people want to have it differently. That means there will have to be a separate arrangement which is separate to the NHI. Now, as far as we would be concerned, the contribution to the NHI will not have to be compromised by the desire of other individuals to find top-up packages that they might use separately. So we expect that the universal health coverage will be funded with the contributions that will come from all those sources, and that if there is any additional, it will be separate to the national health insurance, and therefore that would be seen as a supplementary or top-up service, which basically covers things that are not covered by the NHI. But we don't expect that you can double dip. You want to have services on the NHI, but then you also still want to have discounts on your other program. We don't see that there's a value in that. But the simple answer here is that we expect that all the people of South Africa will be covered under the NHI. Then if there are other services that are not part of NHI, and then it becomes additional, which means it's a separate arrangement altogether. Can you hold it at that? Thank you.
Thank you, Minister. Thank you so much, members of the panel. Colleagues from the media, we really appreciate your presence here, and we hope that if there are any further questions, please direct them to me. I will endeavor to reply to them. Thank you so much.
Let's go. Yeah, I hope so.
Members of the media, would you please join us at the cocktail, please.